Okay, well, we'll get started. So this morning we're very lucky to have a guest speaker from Yale with us from the East Coast, Dr. Sandra Springer, who is a professor of medicine in the Department of Internal Medicine, section of infectious diseases at the Yale University School of Medicine. She is also an attending at the Veterans Administration Connecticut Healthcare System and directs the VA Newington, Connecticut Infectious Disease Clinic. She received a BA from Harvard University, an MD from University of Massachusetts Medical School, and completed her internal medicine residency and infectious disease fellowship at Yale. She has significant clinical and research experience with persons with and at risk of HIV and substance use disorders, including within the criminal justice system. She is the director of InStride, which stands for Integrating Substance Use Treatment Research with Infectious Disease Treatment for Everyone, at the Yale School of Medicine, where she and her team conduct clinical research on the integration of substance use disorder and infectious disease and HIV prevention and treatments. In particular, she's focused on evaluating medication treatments for opioid and alcohol use disorders to improve substance use and infectious disease and HIV treatment. She's currently a principal investigator of 6 NIH awards and 1 VA Cooperative Studies Award. In addition, Dr. Springer was awarded an Avant-Garde Award by NIDA in June of 2022 to evaluate a cutting-edge mobile innovative program to provide medication treatment of opioid use disorder integrated with PrEP and HIV treatment for people who use drugs wherever they live, with mobile pharmacies, telehealth, and community health workers. She has presented her research numerous times, both nationally and internationally, and has published over 100 manuscripts and book chapters. Thank you for joining us again.
Thanks a lot, and thanks for having me here. And it was a really nice introduction. I know it was a lot to say. I appreciate it, and it's really nice to be asked to speak to you guys out there who are also doing amazing work. And so I'm a big fan of many of you. So I'm humbled to be able to speak to you today. And wish I was out in San Diego. It's been a little smoky here in the Northeast from, unfortunately, the wildfires in Connecticut, or in Canada, which are affecting us in Connecticut. But so, yeah, I'm an addiction medicine and an infectious disease physician and researcher, and I'm going to share a little bit. And I know I can't go into it all, but hopefully come away with some of the things that I feel are really important. So these are my disclosures. The learning objectives are really just, kind of going over really the brief epi data about these intersecting epidemics of substance use, in particular opioid and stimulant use disorders that are occurring in the United States and how they're affecting new infectious disease outbreaks, as well as why it's so, and I guess that is why it's so important for all of us, no matter what you do, to be able to recognize so therefore screen and diagnose substance use disorders and be able to potentially integrate care in many settings, including hospital settings and other areas where I work in prisons and jails. And I'm really going to, in the end, really focus on some of the newer, longer acting medications for treatment for opioid use disorder, and how we should really be considering them just like we do other long-acting forms of treatment in other conditions. So this is a little bit of an older data set, and the reason why you'll see why I'm using it, but really, if you've been, the only way you wouldn't know this is if you've been living under a rock, but, people who use drugs are dying at higher numbers now than they ever have before in the United States. And this is, of course, we know from the early prescription opioid epidemic in the late 1990s and 2000s, which was then quickly taken over by black tar heroin coming from Mexico, and then really has just been supplanted by synthetic opioids, mainly fentanyl, which we saw in 2013 really taking off. It's really been a problem in Connecticut for much longer than that. And we really can't forget also the overdose deaths and the morbidity and mortality that are occurring from stimulant use disorders on their own or in combination with opioids or sedative hypnotics. And really, since the late 2018 pre-pandemic, we know there have been multiple failures in our healthcare system, and lots of folks. We saw significant disparities, but among people who use drugs, we also saw a significant rise in overdose deaths, about 30% increase from 2020 to 2021, where now well over 100,000 deaths are occurring in this country. And that number, as you know, recent data has been released showing that the numbers are still going up. And in addition to the direct morbidity from substance use and overdose deaths, we also know there's significant new infections and occurring across the country, including bacterial and fungal infections we're seeing in our hospital settings, as you probably have as well. This is older data, but I like to show just that earlier prescription opioid epidemic, late 1990s, early 2000s, to about only 10 years later, there was a 50% increase in hospitalizations related directly to what we used to call opioid dependence and opioid misuse, including infectious endocarditis, osteomyelitis, septic arthritis, epidural abscesses, and other infectious diseases that I know in my healthcare system here at Yale that we're seeing marked increases that still are going up, especially now since when fentanyl came on the scene for the most part in 2013. In addition, viral infections. So I know this is showing acute hepatitis C infections occurring among individuals, paralleling the initially opioid injection epidemics occurring, unfortunately, among our younger Americans. So yellow is representing the opioid and the hepatitis C rates, solid and dotted lines for the 18 to 29-year-old group, and then in red is including the 30 to 39-year-old group. And again, this is older data, but really led to the changes in our hepatitis C screening recommendations. And then this is not a complete slide, but one I use a lot that I put together from news pieces and other things a long time ago, but emphasizing, and we can't forget that there are actually brand new HIV outbreaks occurring among people who use drugs across the country. Again, the reason why I went into ID is my interest in substance use in the early HIV epidemic, which was I was seeing in the Northeast, or we were all seeing in the Northeast, related to injection and drug use related to heroin and crack cocaine. But with the advent of syringe services, methadone provision, and the Ryan White Care Act, we saw marked reduction in HIV among people who are using drugs. But since that early prescription opioid epidemic highlighted by Scott County, Indiana, when we saw a brand new epidemic occurring among people who were injecting a prescription opioid, oxymorphone, in a state that had put a moratorium on syringe services, didn't, and methadone and other prevention services, really saw this spike in new cases. And since that time, though, it's really been related to injection among fentanyl, heroin, methamphetamine, cocaine, as well as condomless sexual intercourse occurring among people who use drugs in Medicaid and non-Medicaid expansion states. And not here is also an outbreak that occurred in Boston and during the pandemic, Miami, and elsewhere. So we know that individuals are not really also accessing prevention services, including HIV medications prevention, PrEP, as well as I'll show you, treatment for opioid use disorder and other syringe service programs, et cetera. When we think about the infectious disease HIV, our main goal is to get individuals into care as soon as possible and get them on antiretroviral therapy and suppress their viral load. We don't have a cure, but if we can suppress someone's viral load, not only is that helpful for that individual, obviously decreasing morbidity for HIV and non-HIV associated conditions, but from a public health standpoint, if we can suppress the viral load to less than 200 copies per milliliter, if an individual partakes in high-risk behaviors, condomless sexual intercourse, or sharing injection drug use, they cannot transmit HIV to an individual who does not have HIV. So U equals U, undetectable equals untransmittable. And this really, in addition to other evidence-based strategies, led to the Ending the HIV Epidemic plan, right? So if we can test everybody, we can get them into care. If they don't have HIV, we could give them treatment. If they do have HIV, we can start antiretroviral therapy, get them virally suppressed. And if they don't have HIV, give them pre-exposure prophylaxis. And if they also inject drugs, syringe services, with the goals that we were going to reduce new HIV infections by 90% in now 7 years. So, you know, a lot of science, but one of the big things is we didn't really come up with a plan on how to implement these issues, nor did we, I mean, the United States, come up with a way to integrate substance use disorder identification and treatment in this plan. When we think about if we want to get everybody who has HIV virally suppressed, we have a long way to go. This is 2018 data. The CDC is always a little bit behind, and there's recent data that shows similar results and unfortunately showing that our country is way behind other countries in getting to these goals. But if we look at the CDC categories for drug use, you know, it's generally injection drug use, male, female, male-to-male sexual contact, and injection drug use, and look at the HIV care cascade or continuum in that blue bar where that's the viral suppression, you know, that's our goal. We're a ways away from getting to 100% viral suppression. So we have a lot of work to do. We know, and this is not a comprehensive slide, but just, you know, to give you a summary of lots of research that is involved in this, that substance use, whether alcohol, opioids, and even there's some data for nicotine, obviously stimulants, can increase the likelihood or increase risk of acquiring HIV. But among those who have HIV can interfere with the care cascade and unfortunately lead to maybe interruptions in antiretroviral therapy or inability to access antiretroviral therapy, viral and lack of viral suppression. So the public health as well as the individual risk. So we really, really, really need to think about how we can integrate both substance use detection and treatment with our prevention treatment services. So this is nothing new, right? Something called measurement-based care. If you can like screen somebody and diagnose somebody, why not offer them treatment? So this is a well-known scenario we see in many healthcare settings, right? But for some reason, we seem to lack the ability to rapidly do so in substance use disorder. So this is an article from NIDA. The senior author is Dr. Nora Volkow, the head of NIDA. Really, I just underscoring this need that if you could diagnose somebody, why not immediately have an entree into some evidence-based treatments? And in this case, as I'll describe, medication treatments for opioid use disorder. I'm going to really focus on opioid use disorder and the intersection in other infectious diseases. But of course, we could think about this for other issues. So not a new novel idea, screening, brief intervention, initiation of treatment, otherwise known as ESPERT. But I'm just going to really highlight that this is not novel and it can be used, but why isn't everybody doing this? So if we could screen and identify in harm reduction programs, emergency rooms, jails, prisons, other justice settings, primary care settings, specialty care settings, and in the hospital, why couldn't you offer rapid treatment? This is one scale that I developed a long time ago because there wasn't anything to rapidly diagnose and get people who are coming out of prison and jail onto buprenorphine, which was later validated and is now a free scale to be used. What is for what we used to call opioid dependence, now opioid use disorder, and can be administered by a non-clinician. So anyone, it could be a research assistant, it could be somebody that for nurse, non-clinical staff in a primary care setting or emergency room. It takes less than 3 minutes, and a score of 3 or more indicates a diagnosis of what used to be called opioid dependency, now moderate to severe opioid use disorder, with the idea that you could actually start treatment in the moment, which is what we did. So this idea of identification and treatment. So what do we know? We have 3 FDA-approved medications in the United States that all work to treat opioid use disorder, reduce craving, reduce use, and importantly, reduce overdose. Also, as I'll show you, medications that also can improve in those who have HIV, the likelihood of achieving viral suppression. All 3 medications have also been shown to reduce risk of acquiring HIV as well as hepatitis C. So just briefly, I'm sure you're all familiar with these, but the differences in them include where they can be administered and who can administer them, and of course their activity. So methadone, well-established, very effective medication in treating opioid use disorder globally, is recommended by the World Health Organization to be offered, especially integrated with HIV treatment. But you can't actually prescribe it unless you are part of an opioid treatment program, unless you're, say, in the hospital setting for the 3-day rule or other issues. But so there is direct, unfortunate control over who can prescribe that. And then buprenorphine, which is really I'd say one of the biggest, probably if not the biggest, one of the best interventions for reducing mortality in our population. It's became available 2002 or so for non-licensed opioid treatment program providers to prescribe. So primary care programs, me and an HIV clinic, could prescribe this. And, it comes in many formulations. So the sublingual tablet film, but also an implant in the arm that lasts 6 months, and now an injection that you can give subcutaneously in the abdomen every 30 days, and another one that's also going to be clinically available this year. And all also are very effective, less interactions with antiretrovirals, and I'll show you can also improve viral suppression. And then the extended release naltrexone is the opposite of all of these. It's a complete opioid blocker at the mu opioid receptor. Think of a long-acting naloxone. It's FDA approved for alcohol and opioid use disorder. It can be administered monthly, no special trainings, et cetera. But the keys is that you can't start it if you in an acute pain need, acute opioid withdrawal. And it's kind of difficult in the community setting when someone's actively using to initiate, but if can be started, can reduce overdose. And I'll show you some improved viral suppression rates. So we have a lot of really effective treatments here. And I'll show you could be offered integrated with infectious disease prevention and treatment services. And this is just a summary slide. I mean, there's lots of data to support this. So they all work basically. And I just want to put the caveat that buprenorphine and methadone, which are opioid agonists, can also treat pain. And as I mentioned briefly, are really incredibly effective and should be offered immediately in somebody who is undergoing opioid withdrawal and can really alleviate those symptoms. So I just wanted to mention, because this is the area that I've been doing work for a long time, that this idea that you could use treatment for an opioid use disorder to improve other outcomes beyond the actual substance use disorder outcomes. So think about, and in this case, for me, it's been HIV treatment, but also I'll show you some other newer data where we're working in the hospital setting to improve other infectious disease completion treatments like endocarditis, et cetera. So this is just a brief, summary slide. So this was a pilot study that I conducted many years ago, started many years ago, which was right after the FDA approved buprenorphine to be available for someone like me to prescribe. It was part of a NIDA K23, and this was actually after I had started working in prisons and jails, taking care of individuals with HIV, and really seeing that people were not started on treatment for opioid use disorder, and obviously increased relapse. And if they had HIV, they were unable to stay on antiretroviral therapy. So this idea that what if we offered them a treatment that I could use, that they didn't have to go to another clinic, where maybe that could help not only help their opioid outcomes, but also improve the likelihood of maintaining or achieving viral suppression after they were released. And so this is, we just offered buprenorphine. It wasn't a randomized controlled trial. It was brand new to them. They had a lot of experience with methadone. And the individuals who started on buprenorphine and stayed on buprenorphine for 6 months in the green, had a higher and a statistically significant higher percentage who had viral suppression at less than 50 copies per milliliter than those who stopped and started buprenorphine treatment in orange, and those who did not choose any buprenorphine treatment in blue, and included those who were on methadone. And there's an odds ratio. We looked at all this data, and really the idea that buprenorphine, so a treatment of opioid use disorder, could help improve an infectious disease outcome, maintaining viral suppression, was really instrumental. And then the further work that we did. So we later did the quintessential double-blind placebo-controlled trial to really evaluate, could a medication treatment, in this case, the first long-acting injectable form of treatment that was FDA approved in the country to treat opioid use disorder, extended-release naltrexone at that time, could that improve if started before release from prison and jail, compared to, as I said, in a placebo-controlled trial, of improve the primary outcome of viral suppression in people with HIV and opioid use disorder. And the long and the short is that yes, if offered a long-acting form of treatment to prevent relapse, also obviously with their antiretroviral therapy, could improve the likelihood of achieving viral suppression compared to placebo. This was actually shown with alcohol use disorder as well in people with HIV. And then there's other supporting data, but I just wanted to highlight that this work and a lot of other work, finally the International AIDS Society USA guidelines, I was honored to be a member this year with Ellen Eaton. We were asked to, for the first time, have recommendations about integrating substance use disorder treatment with HIV prevention and HIV treatment. And so there's a new box recommendations supporting that screening, treatment, including medication treatments for opioid and alcohol use disorder, and ways to help keep people on treatment that can be difficult, including supporting long-acting forms of treatment. But the reality is that despite all the evidence that treatment for opioid use disorder actually reduces mortality, and in people who have concurrent infections like HIV, and there's lots of data about hepatitis C as well, and that they improve those other outcomes as well, very few people are offered treatment. And then among those who are started, very few can stay on treatment, can retain on treatment. So if you look at most of the medication treatment trials for opioid use disorder, there's really poor retention at 6 months. And then, as we know, when someone stops treatment for opioid use disorder, their risk of relapse is super high and the risk of death is super high. And this is obviously shown in those who are coming out of prison and jail, where the number one cause of death of all individuals who are released from prison and jail is overdose, regardless of how long they've been incarcerated. And similarly, you can think about other controlled settings where someone may not be treated and then released. So from a hospital setting or other settings, we have to really be cognizant of the high risk of death. And also from an infectious disease standpoint, think about from HIV, I just discussed, prevention, treatment, other infectious diseases. This is an older care cascade from 2014, but sad to say it's pretty similar right now. Very few people offered treatment, and then once started, very few people retained. So there's really, and this is one of the things I really wanted to emphasize and talk about here, I've been doing this for a while, is thinking about how we can help individuals. So here in this situation, we're going to talk about long-acting forms of treatment. So you're probably already aware of long-acting forms of treatment for other conditions. So pre-exposure prophylaxis, cabotegravir, antiretroviral therapy, cabotegravir and long-acting rilpivirine. You could think about psychiatric conditions, other things where long-acting forms of treatment, dalbavancin for treatment of Staph aureus. So there's lots of needs for these, but importantly for people who use drugs, as we know, there's like endless barriers. So when we think about this population, could be a very good population that we should be really thinking about using interventions. And in this case, I'm talking about treatments for opioid use disorder, but thinking about things that could help them. So how can we kind of overcome potentially adherence barriers? But, there's transportation issues. So a lot of people can't get to clinics right away, rural versus, situations. But even where I live in Connecticut, it's a small state, but there's no public transportation system. So we actually have areas that are considered rural in the Northeast Territory. And it's really impossible for them to get to, say, a provider in New Haven at Yale, like me, if they live out there, without some assistance in transportation. So could a long-acting form of treatment help bridge somebody while one is working on that? Obviously, stigma is significant. Racism, the housing issue is a significant barrier. Poverty, lack of providers, pharmacies not stocking the medications, and this actually occurs in Connecticut as well. So patients may not be able to get the medications they need. And then I will just, as I said, long-acting forms of treatment could really be helpful. And then thinking about other ways to help provide those treatments. So I don't have time to go into all of that. It was mentioned briefly in my introduction, but now I'm using mobile pharmacies, which were recently approved. The Governor Lamont signed 3 days ago. So from a bill that we recently helped write. So we're now going to be able to go out to people. But I wanted you to think about situations you might be in a hospital situation, other situations where maybe starting a long-acting form could help an individual while you're trying to help them access services in the community. So this is just a summary slide I put together of all the currently FDA-approved long-acting forms of treatment for opioid use disorder, called medication treatment for opioid use disorder, or MOUD. I've already mentioned extended-release naltrexone, known as Vivitrol. The big issues for this is it can work, but you have to be off of opioids for 7 to 10 days. You can't use it to treat acute opioid withdrawal. And if somebody has a comorbid pain condition, this is probably not the right thing because it blocks the opioid receptors and really isn't a pain medicine. Probufene came on the scenes a while ago, but there's been really little uptake. It's the implant put in your upper arm subcutaneously. I went through the training, and it has a slow release for 6 months, like I said, then has to be removed and then replanted. It's about the equivalent of an 8 milligram dose of buprenorphine. Like I said, it's really had no uptake, and especially in the age of fentanyl, we're a little worried that 8 milligrams would not be enough, and you'd have to really provide more supplemental medication. The last two, Sublocade and Brixadi, Sublocade's been FDA approved and clinically available in the United States since 2018, and Brixadi was FDA approved, but not clinically available until we just heard a week ago, or May 24th, that it will be now clinically available in the United States. They're both injections. They both have 30-day injection ability. So Sublocade, it has to be administered in the abdomen, and it creates a nodule, and it has a slow release process, 300 and 100 milligram doses. It needs to be refrigerated. And the Brixadi form comes in a weekly and a monthly injectable form, is similar to the sublingual buprenorphine dose that you might give. It does not need to be refrigerated. So, why, again, I'll just emphasize again, why might we even think about using these long-acting formulations? And really, to improve retention. So I talk about retention a lot. I'm constantly trying to think about how can we improve ways to help patients stay on the medications that they need to. And so potentially for somebody who has a difficult time taking doses or storing medication, especially our unhoused population, really helping people stay on a treatment. So it could decrease the risk of missed doses. So this could then reduce the return to opioid use and overdose, obviously reduce transmission of HIV, hepatitis C, improve the retention on their treatments. Really think about in the hospital or other setting where, if you could start a treatment early, maybe you could help unplanned discharges from inpatient settings and improve their hospital treatment and follow-up post-release or post-discharge. And also, of course, other public health concerns, decrease risk of diversion, and also decrease accidental pediatric exposure, so not having that risk at home. This is just showing you what Sublocade looks like. If you don't know, it's a it's a substantial amount there that you have to get into. The 300 milligram dose a little bit higher, but creates a nodule, and you rotate in the 4 different quadrants of the abdomen. We've been doing it a while. As long as you know how to do it, you really can reduce concerns about pain or other things. This was the study that led to the FDA approval, published by the pharmaceutical company Indivior. Actually, it wasn't even published yet before it was approved, excuse me. But it was a placebo comparison trial, and looking at individuals with opioid use disorder, prescription opioid, and predominantly heroin use. Fentanyl really hadn't come on the scene too much at that time. And really showing you that, they looked at abstinence as an outcome, and those who had the higher 300 milligram doses and the subsequent doses of 300 milligram had about a 41% opioid abstinence compared to only 5% placebo. And this led to the study, which wasn't published then, though, led to the FDA approval. And then there's Brixadi, also known as CAM 2038. It actually was also showed very good data showing that it could reduce opioid use and had very few adverse events, but unfortunately it hasn't been available clinically because of manufacturing problems. But they actually did have a study that was published that compared to sublingual buprenorphine. And as I just quickly highlight here, by Michelle Lawful at University of Kentucky and colleagues in JAMA in 2018, which actually showed superiority of injectable monthly buprenorphine compared to sublingual buprenorphine, again, in relationship to opioid abstinence. So I know I don't have a lot of time, but the 3 populations that I've been working with on trying to improve treatments for opioid use disorder include, of course, people coming out of prison and jail, which has always been a population I'm working with. I'm also a VA doctor, as was mentioned, and the veteran population, which has a much higher rate of opioid use disorder and overdose than in the general population, and hospitalized patients. I think I've already made this point, but opioid use is common in this population, unfortunately, and sadly is opioid relapse and overdose occurs quickly post release, regardless of how long they've been incarcerated. So really identifying ways to improve treatments, including a long-acting form of treatment, to help bridge people is really critical. And then, of course, from my standpoint in infectious disease, as I've already said, if we could start people on treatment who have HIV, we can maybe help improve their HIV outcomes as well. So this is, I'm not going to go into it, but we are conducting the first trial comparing long-acting buprenorphine to long-acting naltrexone. There is another trial going on with friends that's a similar one, but using the Brixadi product. We're using Sublocade and comparing in people who are either coming out of prison and jail or those who are in the community who have justice involvement. And it's a 6-site study. Josh Lee is the contact PI, and I'm one of the MPIs, but we're doing this in New York, New Jersey, New Hampshire, Oregon, Delaware, and Connecticut. And the primary outcome is looking at retention on study treatment, but we're also evaluating HIV and hepatitis C testing and risk, as well as obviously overdose and other things. The veteran study is the first study actually comparing sublingual buprenorphine to long-acting buprenorphine, Sublocade. That's the only one that's being done so far. We're doing this in 20 sites nationally in VAs across the VA network in outpatients. So who have veterans who have opioid use disorder. And we have 2 co-primary outcomes. So we're looking at retention on treatment as well as abstinence. But importantly, we're also doing a really detailed secondary outcome analysis that includes HIV, hepatitis C, as well as hepatitis B testing repeated over a 12-month time point. So this is the longest medication treatment trial. It's monthly for 12 months, as well as evaluating infectious disease admissions in hospital situations and other really key outcomes. I just wanted to emphasize this was the data before we did that study showing you sublingual buprenorphine in the VA health system, Veterans Health System, which is the largest health system in the United States. and has significant directives to identify people with opioid use disorder and get them on treatment as soon as possible. If you looked at the 12-month data, individuals who were started on sublingual buprenorphine, only 35% were still on a form of treatment in this particular healthcare system that has probably higher ease at acquiring specialty treatments for this population. And unfortunately, if we look at some of the data, and I just did, and I can't report it here because it's under review, but the data looks about the same or worse, actually. So this idea that, you know, we really need to think about how can we improve the likelihood of retention. It could be long-acting buprenorphine, or it could be other things, or a combination of things. So that study is ongoing, and I can't present any data right now. Obviously, I can't even look at the data for comparisons, but hopefully in the next couple of years, we'll have some more about that. And the last one I really wanted to focus on is hospitalized patients with opioid use disorder. I really made, I already talked about this, but, you know, just to remind everybody, many of you are infectious disease clinicians or just hospitalists, or you might be cardiothoracic surgeons or others, but you're seeing a rise in a significant number of people who are being seen in our hospital settings across the country with serious bacterial and fungal infections. And you've obviously also probably experienced this. If patients aren't recognized they have an underlying substance use disorder and are not treated for that, that can undermine their ability to stay in the hospital and receive treatment. They can undergo withdrawal and you know, start having craving. And then despite no matter what we do, even if they're undergoing serious surgery, they can't stay in the hospital, and they require needing to take treatment. So if we, for opioid use disorder, and may need return to use because of the concerns or feelings about craving. So maybe we could help if we could identify people earlier, get them onto treatment, and hopefully bridge them and do proactive outpatient clinic assessments as well, and appointments. So we have a multi-site trial called Project Commit, Coordinated Opioid Use Treatment Through Medical Management with Infection Treatment. It's a UO1, it's a National Center for Advancing Translational Science study. I'm the contact PI, and you can see the other PIs listed that have lots of expertise: Kathleen Brady at Medical University of South Carolina, Ned Nunes, and Francis Levin at Columbia. And we're doing this in 3 sites, as I'll talk to you about. This was the protocol paper. If you want to know the details, this was published a couple of years ago. But really the primary aim was, when we wrote this was probably, I wrote this 2017 to 2018, was this idea that if we could integrate infectious disease and opioid use disorder treatment using a long-acting form of buprenorphine with infectious disease management for patients who are hospitalized with an infection and found to have opioid use disorder, compared to what was treatment as usual, could we improve the likelihood of them being on a form of treatment post-release or 12 weeks after randomization? Could we improve, obviously, opioid outcomes? And then, importantly, could we improve infectious disease outcomes? Could we improve antimicrobial completion, improve antimicrobial or infectious disease cure, which I can't go into all this at the moment, but happy to talk to you about how we're identifying and recognizing and evaluating that. But importantly, also decreasing rehospitalizations and emergency presentations for that underlying infectious disease and opioid use disorder. So this is a randomized controlled trial, 200 participants, 3 sites, one in Penn State, Pennsylvania, one in South Carolina, Greenville, South Carolina, Prisma, and then the other in New Haven at the Yale Hospital Healthcare System. And it's a 12-week intervention. If they get randomized to the long-acting buprenorphine, they continue to get that every month, excuse me, for 3 months. And then we work with only community organizations that can continue the treatment if the patient would like to continue doing that. So it's not like they're cut off if they want to continue it. And then we do a 26-week assessment. I've already said why, and I think you guys probably see this in your hospital settings, but I really wanted to know, like, can't we just do this? Can't we integrate infectious disease and opioid use disorder to improve outcomes for this population? And I think the first thing is identifying. I've already talked about this in the beginning, but there's no hospital system that I am aware of, and I hope, I want someone to prove me wrong, that is doing a routine screening of all substance use disorders for all patients who are coming in contact with our hospital system. If it's happening and it's happening in your hospital, that's awesome. But we don't have that, certainly. So we had to create a way to identify everybody. And so we run electronic medical records. Again, this is 3 different hospital systems. So not everybody has Epic. So everybody has to create their own. We use ICD-10 codes of the typical things like opioid dependence and others, but we know that a lot of clinicians don't diagnose and may not code correctly. So we had to be broader, including, other things like history of overdose, unintentional poisoning. We look at hepatitis C, altered mental status, not just opioid use, but other maybe reported substance use, and really kind of evaluate everybody. And then once they're before I go into that, once we've identified people, we do a careful chart review and then go to the patient's bedside. And if they consent, we can do a rapid opioid use disorder assessment and go further. And we also, of course, in this situation, have to identify if they have a concurrent infection. For this situation, we take any infection. So it could be viral, HIV, hepatitis C, they have to have, or even COVID-19, as well as, of course, bacterial infections, fungal infections, et cetera. And I just wanted to highlight some of the early characteristics. This is an ongoing trial, so I can't present the primary outcome data, but I really want to emphasize this is a current trial. This started right when the pandemic hit. So, we were allowed to start in July of 2020 because the Yale Health System and the IRB at MUSC realized this is a life-threatening condition too. So we were going in right in that early time, pre-vaccine, all of those issues. And so, we are upwards of 150 now, but almost 50% are persons who identify as female. Importantly, about 50%, 55% are covered by insurance. It's upwards of 44% now that are unhoused. A lot of significant depression, 66%, PTSD, 67%, and the pain we also assess too. About 23% have concurrent hazardous drinking, and you can see opioid craving is around 4 out of a 1 to 10 scale. And then I just wanted to highlight what are the infections that we're seeing. So obviously you can have more than one, but the top 4 are highlighted in purple. So bacteremia, they could have bacteremia and infectious endocarditis. Hepatitis C, this means they had detectable viral load. For this study, we do HIV, hepatitis C, hepatitis B testing. We either ask the hospital teams to do that or we do the testing ourselves. And I really wanted to point out a couple of things. One, as I said, these are, the newer data of our 150, upwards of 50% now have active detectable viral load for hepatitis C. We're never offered direct acting antiviral treatments. So really a reachable moment. I'm also going to say that 98% of our current population we do HIV testing on do not have HIV. Nobody except for one has been offered PrEP. And this is a current study. So again, hospitals as reachable moments. Just want to identify what we're seeing. We're seeing, obviously they all have criteria for opioid use disorder, but also stimulant use disorder in purple is very concurrent, very common. And when we look at self-reported substance use in the 30 days before hospitalization, heroin in the middle and fentanyl are the top 2. And stimulants in this case means methamphetamine. We also have a separate category for cocaine in this otter green color. And then this is just showing you the mean days of use in the last 30 days. So there's a significant amount of use, upwards of 17 days in the last 30 days of what they reported as heroin, 9 days of fentanyl, and then stimulants in the pink in the bar is upwards of 12 days in the last 30 days. This is the urine toxicology data. Again, a patient can get referred to us and not be on the day of admission. So we're not, catching all positive urine toxins, but fentanyl was quite common. And just to show you the structure, we do randomize as soon as possible if they are consented, and we can start long-acting buprenorphine even on day 1 if possible. And I just want to emphasize that everybody, regardless of treatment arm, including the treatment as usual group, gets education about the diagnosis, gets recommendations about treatment for opioid use disorder, including all the forms of medication treatment, gets opioid overdose education, naloxone prescription, safe injection procedures, and then has assertive linkage to providers in the community with also nurse-led medical management calls daily while they're in the hospital, and then weekly to help them, as well as transportation assistance and other things. These are just some samples of the educational materials that we give to all persons. This is overdose education and then safe injection. So as I said, we have an IND from the FDA to actually start long-acting buprenorphine quickly. So we can do it on day 1 if possible. And we do that in several situations. We created a safety sheet on how to do that. And this is published in that protocol paper. But we've had a lot of challenges, importantly related to fentanyl. And this is just one patient case, and probably someone like you might have seen in your hospital situation as a young man using heroin and fentanyl daily, also benzodiazepines, has bilateral upper extremity cellulitis and skin abscesses. He had been on methadone in the past. They had missed it, obviously hadn't been going. They restart that at 150 milligrams, plus they give him oxycodone for pain, and he gets debrided. He's interested in the trial, he consents, and he's randomized to the long-acting buprenorphine arm. And I don't have a lot of time to go into this, but there's a lot of things we've learned. And you have comorbid pain. These people are very, very sick. We don't want to precipitate withdrawal. We don't want to, cause any problems. And typically, if you were to start buprenorphine in this clinical setting, you have to stop, you have to wait till they're in withdrawal and then start it. But you can't do that in patients who have ongoing pain and really need opioid agonists, especially our patients who are undergoing cardiothoracic surgery for valve replacement. So we have had to, with our addiction medicine colleagues at Yale New Haven Hospital and our colleagues who don't have an addiction medicine consult service in Greenville or Penn State, really developing these low-dose buprenorphine strategies to help continue their pain management and other long-acting opioids, including methadone, so that we can safely get them onto long-acting buprenorphine. And I'm not going to go into all this, but a recent case series from this commit trial was published in Journal of Addiction Medicine and goes through that. And this is just showing you they have a lot of issues, including many Staph aureus valvular infections, and that the pain, we measure pain scale and made sure we weren't increasing the likelihood of pain. And this is just from that article, shows you how we did it. So the little buprenorphine doses are started in the little red check circles and stuff while you're continuing in the orange, whatever opioid they're on, as well as in the blue or purple methadone. And then the stars indicate when we could start the long-acting buprenorphine. And everybody was safely able to start that, no increased withdrawal. We had very little serious adverse events. And there were 3 deaths at the time of this, and none of them were related to receiving long-acting buprenorphine. So, it's safe. The key takeaways I just want to say is it's safe, it's acceptable, it's feasible, to start in this particular population that can be very sick. And the overall conclusions just coming from what I've talked about, I hope you come away with understanding these intersecting epidemics, that we really should be, all of us, no matter what your role is, should be trying to identify and think about how you can get people onto treatment. And really thinking about long-acting formulations, why shouldn't we offer them? Why should we wait till people fail? Failure could be death. And you have this reachable moment, especially say in hospital settings or prisons and jails, where we could offer people potentially life-saving medication that not only could improve their opioid outcomes and reduce death from overdose, but also other things like infectious disease outcomes. So I just want to acknowledge everybody, obviously the participants, the research teams, the funders, the collaborators, and really, thank you for taking the time to listen.
That was incredible. Thank you so much. I have a couple questions in the chat that are comments and questions. If
Sure.
It's okay. All right. So one of the questions from Jill is, what do you think is the biggest barrier to access to the different options for opioid use disorder? We have only methadone and oral buprenorphine right now at UCSD.
Yeah, so it sounds like, Yale New Haven hospital system was recently, the latter part of last year and really February of this year, where Sublocade was put on formulary, and the VA, it's now on formulary as well. So I think barriers, we have to think about, talking to your pharmaceutical pharmacy, whoever the powers are that are making these decisions. So if it's a cost related issue, why is this something different? Is there something different for this particular condition or others? And do you really need to wait for data to show that if you could help identify and get somebody on a long acting form of treatment that could bridge somebody that they want, that could, help that individual? I mean, why should we wait? So I can't say, I would just say you have to be more vocal and be at the table, and just questioning that, why, there is data actually to support potentially superiority of a long acting form over a sublingual form. But it's really should be from the patient's perspective. We have these effective treatments, and why should we decide whether one is better than the other? We need to have conversations with our patients and determining what is best for them.
Okay, I'll go down these comments. So next is from my understanding, longer acting injectable alternatives are significantly more expensive and are bundled into charges. When given inpatient, they can always be given and started through the clinic and follow up as an outpatient.
They could be started in the clinic, that's true. But again, that reachable moment, right? You have somebody who's in the hospital setting who potentially may need to leave, or you missed a reachable moment. So yeah, you could start it in the clinic, but the other things, can they get to the clinic? So we have a huge issue with patients actually making it to their brick and mortar clinics. Again, something that I'm trying to do with my group is trying to figure out how to get to people and not expecting them to come to us, that we need to help try to go to them. But if you have a reachable moment, why not offer it then?
I think in our hospital, and probably true across hospitals, is many of these patients leave what we used to call AMA, self-directed discharge, of course. So if they're, I think if they're offered it during the hospital stay and they're interested, then it's especially important too, because they may not stay till they get an appointment.
Right.
Okay, another comment in the chat is, I'm just wondering, has there been any thought about a study that requires observed exercise for 20 to 30 minutes? My thinking is maybe endorphins one receives from implementing exercise assists with possibly a higher propensity for the patients to stay on the medical treatments. Just wondering. Of course, mandatory counseling as well. And Carla Crudup, who made the comment, I don't know if you want to add anything to that question. But.
So, oh,
Hello, doctor. Yes, I was in my mind, I was thinking if there was some endorphins, maybe that from a systemic standpoint would create a natural form of a certain percentage of opioid suppression by just a little bit of regular exercise, and maybe a study involved with that.
Yeah, I can't, I mean, definitely exercise has been shown to improve well-being and other things. The unfortunate problem is for this population, any use can lead to death. And so we have effective treatments, medication treatments actually reduce the risk of death significantly. And we have an opportunity to provide medication. They're safe. Mandatory counseling actually has not been found to be effective in preventing relapsed opioid use and craving or death. It should be offered, but it's not. None of the current guidelines, including American Society of Addiction Medicine, American Addiction Psychiatry, or others, recommend mandatory counseling anymore. It should be offered, but all the other strategies, yes, exercise, other things can be very helpful. I don't know of a study offhand integrating that with treatment of opioid use disorder, medication treatment for opioid use disorder, but maybe others do.
Thank you, Dr. Springer.
Okay, so there's a comment from Nettie. In our outpatient FQHC system, we are implementing universal screening and referral to treatment, and I think it's very important that this to be done in multiple settings. Also interested in your thoughts, experience with stigma and discrimination that might be occurring with widespread use of screening in settings where those administering the screen and receiving the results might not be as educated about or accepting of people who use drugs. Unfortunately, this describes many healthcare settings.
Yeah, so stigma, without a doubt, is probably one of the worst problems facing, not just, from us, from healthcare providers, as well as individuals who live in the community. So I think that goes to the training that you have to do and incorporating and reminding everybody that this is, I say this a lot, and I'm sure you hear this a lot, but just think about, would you ever not provide, I don't know, diabetes medication or treatment to somebody who came in and saw you? What would you, what would you say to that person if they, were unable to comply with your regimen? You wouldn't say, oh, sorry, can't provide that treatment. So we need to really change. We're not, and I actually don't know anyone who, maybe you guys do, but I don't know anyone who hasn't been touched by substance use in some form. And it's worsening. So I think the stigma issue, really talking and training the people that we're working with who are doing the testing and the treatment to control their, hopefully work on their own personal attitudes, but, really think about it and how you can actually link them with, if it's not your organization, link them with an organization that can provide treatment and prevention services. I would love to have everybody actually be able to provide it in the moment because it's a reachable moment. But if you can have in the moment access to services for people who actually say they would like treatment, that would be good too.
I'm going to scroll down because we answered or talked about some of this, the questions before, but Carla mentioned Carla Marenfield that while the data on 6 months retention isn't stellar, maybe 60% for bupe, higher for methadone, there's lots of starting and stopping. That's why the long-acting injectables are so critical. And then ED Seville said the problem we're having with getting sublocated Family Health Centers of San Diego is that it's controlled substance and the clinic doesn't stock controlled medications because of regulatory requirements.
Yeah, so that's
actually, if I could, I was going to say, sorry, this is Carla. I was just going to say, it's not that hard to do the application to be able to have the controlled substances sublocate. It's a pretty simple application. I'm happy to be a resource if they have questions, if the clinic management is accepting of it. I think that's the bigger barrier, not the application itself.
Yeah, no, the application is super easy. It's just a REMS procedure and there's nothing magic about it. But I agree. Yeah. So talk to Carla. I think the big thing is the issues of stigma and certain opinions. There really should be no reason why you can't have that available. Yeah. So we're right now, just to let you know, it's another talk. So there's a NIDA or NIH webinar on integration of substance use treatment and lots of things from the pharmacy perspective, I think June 28th and 29th. And there's lots of folks that are going to be talking about, I'll be speaking about using collaborations with pharmacists and mobile pharmacies to provide substance use, opioid use disorder treatment and prevention, and HIV prevention and treatment services for people who use drugs. But California, you guys are one state that had mobile pharmacies approved, but only for government municipalities and not including controlled substances. As of 3 days ago, our governor signed retail mobile pharmacies. So we'll be the first state that has retail pharmacies. And I'm actually petitioning the DEA right now to remove their restrictions for the mobile component, because if a retail pharmacy can stock and have controlled substances like buprenorphine, a retail mobile pharmacy should as well. So talking to them as well. And I'll be talking about that on that webinar. Yeah, I think it just comes down, you guys can, you can change the moment and you just have to be vocal, and I hope whoever's listening, if there's any hospital administrators or others out there, that you really can save lives. You could reduce readmissions, you could reduce death. If you could have an available long-acting form of treatment that patients could use in a reachable moment. I keep saying that hospitals are really, you have healthcare providers all over the place and options. So it's a really good place to think about starting treatments.
I hate to cut us off, but it's past 9 o'clock.
Thank you.
And we really do need to end this. This was incredible. I'm so glad that Amu invited you, and I hope you can scroll through the chat to see all the praise and questions. And so, oh, sorry, Amu, I don't know if you wanted to say anything else, but we should.
I'm just really grateful for you. Thank you so much.
Well, thank you. And I wish I was in San Diego with all of you.
Please come visit us.
Yes.
You guys are doing such great work. Thank you for including me.